Hello everyone, my name is Dr. Martin Antonio V. Reyes from the Philippines, and on behalf of the Association of Philippine Orthodontists, I would like to congratulate the organizing committee of the 9th International Orthodontic Congress. You truly have served as an inspiration to all of us to make this virtual conference a reality. My lecture for today is Pre-Restorative and Prosthodontic Orthodontics, Balancing the Aesthetic and Functional Needs of Our Patients. Now, before we continue, I just like to say that I have no financial gain from any of the materials that will be mentioned in today's lecture. Now, for our lecture this today, I would first like to give a few learning objectives, which is to review the concept of a broken occlusion. Second is to emphasize the pre-restorative orthodontic treatment importance in clinical practice. And finally, to apply some basic pre-restorative treatment planning techniques and principles in your actual clinical cases. Okay, so we will have a 30-minute lecture for today. I will spend around 5 minutes going over the concept of a broken occlusion and the ortho first philosophy. And then we'll spend around 10 minutes I will be sharing with you some treatment planning considerations, especially for pre-restorative orthodontics. And finally, to illustrate the points we've discussed today, I will share some clinical cases for around 15 minutes. Okay, so with that, we will begin. So the clinical cases I will be sharing with you today is I'll be sharing one clinical case relating orthodontics and restorative dentistry. I'll also be sharing one molar uprighting and intrusion case wherein mechanics will be used to fix a broken occlusion. I will share some ortho first concepts for prosthodontic treatment. And finally, if we have time, I will share one combination case to summarize all our points today. So the concept of a broken occlusion has to do with how we look at it in dentistry. So the definition of a broken occlusion, it is that by which it is an occlusion that is compromised by poor and unfavorable contacts of the natural teeth, which is detrimental to the health of the patient. And more often than not, it will need multidisciplinary rehab with orthodontics taking the lead. So let's go first to what a normal occlusion is. A normal occlusion, although not ideal, although it may deviate from what we strive for, the key component of what is normal is that it shows no pathologic manifestation or signs of dysfunction. That cannot be said of what we see in a broken occlusion. A broken occlusion is one that is detrimental to the health of the patient. So why orthodontics first? Well, let's look at some literature in our journal readings. This one that was published in January 2019 actually shares with us the rationale and reason for doing orthodontics before any type of restorative work. And essentially, the goal is to provide a stable oral environment to ensure the longevity of your dental restorations. So let's take a look at this case here. Okay, as an orthodontist, you might probably notice first the class 2 occlusion that the canines and probably the molars will manifest. But let's look at the case in its reality. This is one of the best examples I can share with you of what a broken occlusion is. Because not only is the patient now missing teeth, you have a lot of shifting of the dentition together with movements of the teeth that are detrimental to the overall health of the patient. You will see some extrusive movements of the molars over here. Okay, and you have the shifting of the teeth compromising the midline of the upper arch. Then if you remove these root fragments, you will have a long span edentulous area. And the sad thing for this case is this patient is only 18 years old. Okay, this is what we mean when we say that this type of occlusion can be detrimental to the way of life of the patient. as she continues to grow up. So we'll see what we can do for her later in this lecture. So let me first discuss with you some treatment planning considerations that we use for pre-restorative orthodontics. So it's already been established who needs orthodontics. Essentially, those with malocclusions, patients will benefit from those types of orthodontic treatment that will fix the bite. But slowly but surely, we're starting to see now that more and more literature is coming out showing the need of orthodontics in order to enhance and improve restorative dentistry, because restorative fillings, even crowns and bridges, veneers, will surely be more stable if some orthodontic treatment will be done first. And when you have a stable restoration, quality of the patient's life will be a lot better. So essentially, the rationale for doing this would be to preserve and ensure the longevity of our dental restorations. Dental restorations will last longer when optimum occlusal relationships are achieved. Some questions that you might want to ask yourselves is regarding these cosmetic restorations. How long do they last? Okay. Second, are these cosmetic restorations really conservative when patients want to hide the imperfections of their teeth? And what is the main drawback of such cosmetic restorations? Let's take a look at this case here. Most of the time, patients would just like to focus on the upper teeth, giving an illusion that the teeth are healthy and well aligned. But over a period of time, especially if the bite is not in its optimum setting, you can have situations like this where you have, over a very short period of time, failure of the restorations. Okay, here's one case I'd like to share with you. This patient is 24 years old. He was applying for a job as a flight attendant, but he was rejected simply because he had poorly aligned front teeth. So he wanted to have veneers. Okay, let's take a look at his teeth. If you look at this particular case, you have a high cuspid here over on the left side. You have midlines that are deviated. You have constricted tapered arch forms. This is an ortho case to begin with. The problem here is that he would want to have the treatment in 3 months, okay? Because he's going to go back for an interview and try again. But is it really a quick fix when you weigh in the short-term and long-term effects of what you're about to do? As general and specialists and general practitioners, we make an oath not to do harm to our patients when we're treating them. So is the cosmetic approach really that conservative? So the cosmetic dentist might face a challenge here by having to cut this canine, probably do a forced root canal, and probably hide this crowded tooth by cosmetic fillings. These are questionable cosmetic situations that may be non-reversible in the future. Okay? So what are the disadvantages of veneers? Well, most and foremost, they're non-reversible. Once you do them, you cannot bring back the natural shape of the teeth. And the problem with veneers in relation to the dental health is that the most common form of repair when they eventually wear out is replacement. And every time a veneer is replaced, okay, because of the questionable retention, more and more tooth structure becomes obliterated, and thereby giving the patient more difficulty as they get older. So our conservative treatment plan for this patient is what we would call orthodontics assisted restorative dentistry, wherein we will avoid veneers. We will maintain the vitality of all the teeth. We'll give the patient more options for the future and just provide him his particular needs at this point in time. To give him an option for aligners also in the future is a good option. So remember, this case has to be finished in 3 months because he's applying for that job again. So we proceed with the preliminary alignment of the teeth, doing as much as we can to just straighten the teeth to allow our restorative dentist to come in. So this is after the braces were removed in 3 months. This would give our restorative dentist just enough room and space to hide the defects. Now, when the patient goes back for his interview and is accepted, okay, then he has more options. Okay. So this is the kind of case that we would call it a temporary fix, but at the same time, you are not making the results irreversible. You give the patient's option. Now, how about orthodontics and prosthodontic rehab? Okay. Let's look at this article regarding extracoronal restorations and crowns. Major components for a successful crown would be to look at the material properties and the strength of the restoration. But this article also shares with us that occlusal control and biocompatibility are essential components. So therefore, when you plan for prosthodontic treatment and you plan to involve fixing the occlusion first, okay, that's where the orthodontics comes in, wherein you manage and fix the poor occlusal contacts, you do some strategic placement of the remaining teeth, and once you do so, proceed to your full mouth rehab. So I will share with you some updated mechanics, particularly in molar uprighting. This journal from the JCO, published in 2013, gives us specific updates on how we can improve the quality of uprighting molars. And they point to, in particular, skeletal anchorage to help the uprighting of the molars in order to ensure periodontal stability. Okay, so therefore, the trend now is more often than not, when you are uprighting molars, especially in adult teeth, there are more benefits when you use skeletal anchorage or mini screws to assist you in the process, especially if there are long span edentulous areas in the oral cavity. There are more benefits definitely when you assist your molar uprighting mechanics with TADs. I'd like to share this case of a 35-year-old patient who unfortunately had braces for 12 years. And after 12 years of treatment where there was no improvement, this is the kind of bite that she had. Okay, let's examine this bite. The chief complaint of this patient was she wanted to just align her teeth and probably close the spaces at the bottom here, distal to the second premolars. The problem with this case is while the previous orthodontist was trying to upright the molars, okay, extruding them in the process, you have this extrusion of the molars leading to an open bite. So the uprighting mechanics is what we use in the university for the longest time, using loop mechanics to bring out the teeth. For our residents who are listening in, these are some effective mechanics. Yes, we teach this in school. However, on many occasions, if the force application is not sufficient or is too much, you have this bone resorption, angular bone loss, that is in many ways iatrogenic. Okay, so we modify this treatment plan wherein we will have to first do periodontal management. The patient will have to undergo periodontal treatment. Okay, we will do some strategic bonding to help fix the malocclusion, and we will use TADs to assist the mechanics for molar uprighting and a little bit of intrusion. So we go back to our radiograph here. The patient is under periodontal treatment. We were given the go signal to jump in and start to fix the occlusion. So what I did was I just placed the buccal tube on the third molar, placed the screw in between the 7 and the 8 to intrude the molars after I've aligned them. So we start with alignment of the 2 molars first, and then we place our screw to intrude the molar, and in 8 months, this is the best that we could do. But since the patient has already been wearing braces for 12 years, finishing in 8 months from our end, she had more important dental problems to face. in particular the periodontitis and also the loss of attachment here in the anterior region. Okay, so essentially this is where skeletal anchorage can help and make the treatment a lot faster in achieving your objectives. Okay, the second aspect of fixing a broken occlusion is in the strategic management of missing teeth, particularly to decide where to move the adjacent natural teeth. So we go back to our article. This article that was published in January 2019 specifically shares with us mechanics for long span edentulous regions in the posterior teeth. And rather, it shows us very good ways, and it shares with us the rationale of why we must control our forces, especially for long span edentulous areas. So it shares with us guidelines for the management of occlusion with missing teeth, specifically those for long span edentulous areas. So first, you have to assess the long span edentulous areas. Is there enough bone? For anterior teeth, if you're going to rehab areas with missing anterior teeth, what is the importance of what we call an emergence profile? Okay, third would be ensuring occlusal stability of the prosthesis with the improved occlusion. And finally, you have to be able to balance between the realistic results from the impossible requests that the patients may have. Okay, so here are some clinical cases. This is one rather easy case because the edentulous area is just in one quadrant over here, okay, wherein the teeth have already drifted. So this is what we would consider to be a broken occlusion, some extrusion of the teeth because of the loss of antagonist. But what's working for us over here is that we have an intact left occlusion. So this is rather easy to fix. We just have to manage the midlines, consolidate them. And it's within a period of 2 years or less, it's rather easy to fix because you have only 2 isolated cases wherein you have loss of teeth. Okay? But when it gets a little bit more complicated for other patients, wherein there are other side effects of the broken occlusion. In this particular case, you have badly broken down 7, and then you have a dentoalveolar open bite that is causing an imbalance to the occlusion. This is a little bit more challenging. So what we do in this particular case is that, well, this first of all, this was beyond repair. The lower right second molar had to be extracted. So we just level and align the arches first. Okay, this was done for around 8 months of alignment and consolidating the spaces. And I did not see him for over 100 days because of the quarantine brought about the COVID-19 virus. So it's a blessing that we were able to control our mechanics for more than 2 months of absence. Okay, after the quarantine period in our country, I was able to put a screw to help align this molar here, similar to the case in the journal reading. And molar is now uprighted, the screw is removed, and we're just going to start to proceed with the detailing of the bite in preparation for the bonding. So this is what we mean when we're actually planning for prosthodontic cases. We just have to strategize and set where we're going to put the teeth. Now, treatment planning for missing anterior teeth can be a little bit trickier because of the aesthetic component and the high demand that the patient will have for excellent results. So this journal readings say that when planning for missing anterior teeth, interdisciplinary management is essential. And we are also faced with the dilemma of deciding which would be better, space closure or prosthetic replacement. In order to come up with an answer, okay, essentially there are always 2 sides to an issue. And I've seen so many journal readings saying that space closure would be better than a prosthetic replacement, or the other side would be prosthetic replacement is more ideal. We go to the what we call this basic prosthodontic principles. And what I would like to share with you is the concept of the emergence profile. This is the concept that will help us decide which would be better, because no two cases are the same. It would be the emergence profile of the final restoration or the tooth that will help you decide whether space closure or prosthodontic replacement will be applicable. So a proper emergence profile will help you make that decision whether or not to move the tooth to take the place of a missing one, or to help you decide whether it's best to have a restoration. But first and foremost, that emergence profile will address two issues. Number one, a good emergence profile of a natural tooth or a restoration is one that will avoid soft tissue inflammation around the periphery of the crown or the natural tooth. And a well-executed emergence profile must simulate the natural eruption of the enamel or porcelain that comes out from the gingiva. So when you're going to analyze your final restoration, you have to determine what kind of emergence profile it will have in the spot where you're going to move it. So let's take a look at this particular case here. This is a 16-year-old boy, and he is missing the right central incisor. This is the lateral over here. One might think since we can move the teeth, maybe one option would be to move the lateral here in order to help bring this canine down, preserving the premolars. Okay, but the problem that we have here is that the midline has shifted, which is one of the features of a broken occlusion resulting from missing teeth. So that's the problem, that if you simply move the central over here, you will still be off midline and your canine relationship will still be class 2. And what kind of emergence profile will you have with a lateral incisor taking the place of the central? So in this case, we left the space open for an implant that will be placed on the central incisor later on. Here's another case. This one has an open bite. Okay, and what the patient is missing is a central incisor. So we fix the bite first, fix the occlusion, set the occlusion to class 1 on both sides, and leave this place here for prosthodontic rehab via implants. Missing lateral incisors can also be a little bit tricky in this particular sense, because now you have a criteria for implants. So normally implants will need 7 millimeters of space for one fixture. In this particular case, the shifting of the teeth has made the space too big for an implant. Okay, so therefore, it's much bigger than a 7 millimeter space. So if I have one implant over here, this will be difficult. So part of the treatment plan is to move the teeth and align them in such a way that we can move and reduce the space with the tooth movement. And once we get our 7 millimeters, patient can now be prepared for the dental implant. Okay, and the midlines are restored. So let's help our 18-year-old patient that I shared with you a while ago. So the chief complaint of this patient is she's missing some of her front teeth. So we have missing incisors, okay, and then we have extruded molars, the back, and this will become a long edentulous span. Okay, and we have a complicated implant placement because rather than just putting 2 implants, the space is kind of too big for 2, but too small for 3, and the teeth have shifted. So even if you're going to put 2 implants over here, the midline will still be compromised, and the occlusion is still nowhere near optimum levels. So these teeth were extracted. Unfortunately, the lateral incisor was also extracted. Now, in this particular case, when you extract the lateral incisor, because of the internal root resorption, one good development that we have is that the premolar of the patient is actually almost class 1 with the lower canine. So in this particular case, we can do tooth movement to actually protract the canine and now serve as your new lateral, solving your midline problem. So essentially, since we had no teeth in this area, we used a mini screw, okay, placed it right here above the the artificial teeth and moving the canine forward. If you notice, with the extracted lateral incisors, the simulation of the natural teeth can now be on midline. Okay, and as we are moving the teeth, later on we will put a screw to protract the molars here and put an implant, restorative implant here for this long span area. Okay, now patient took selfies. Because of the quarantine, she was not able to see me for over 2 months. She sent these pictures to me because I like to get updates from my patients. I encourage them to take photos of themselves. She sent this photo and showed me that things were going well. The canine is now moving into where we want the lateral incisor to be, and we will continue moving the teeth. This is an ongoing case. I have not seen her for over 3 months already, but so far she is doing well. Okay, now to wrap it up, I have around 4 minutes left. I'd like to just share with you one final combined case to summarize all the principles we've discussed today. This is a 37-year-old female with a chief complaint that her upper restorations are now leaking and there's a little bit of discomfort. And she would also like to correct the crowding of her teeth, and she's also concerned with her profile. So in this adult feature, the problems that we have is that we have protruding teeth with crowding, multiple restorations with missing anchor teeth that we will see later in the x-ray. Periodontal health might be a little bit compromised, and like all adults, they would like to be finished at the shortest possible time. So case considerations, we probably have some anchorage issues. Our molars might, especially on the upper arch, might not serve well to be our anchor units if we want to retract the anterior teeth, and our multiple restorations will have to be fixed. I'm sorry for the quality of this x-ray, but you can see here that these molar areas, root canal treated teeth, will serve no purpose as being good anchors to facilitate the retractions we intend to do, because the patient has what we call bidental protrusion. So we do the clearance first for periodontal, get the periodontal clearance, restorations will be changed, and we use TADs to retract the anterior component. So these restorations will have to be removed over here. So as you can see, our molars have no capacity to serve as good anchor units, so we put a couple of TADs to serve as our anchor, and this will be the one to retract the teeth after we extracted the first bicuspids, and then we retract the teeth with the mini screws serving as the anchor, aligning the teeth normally at a normal pace for the lower arch. Okay, and once we are done retracting, we can now remove the screws and prepare the patient for the final restoration. In this particular case, she had some new porcelain fused to metal crowns, and the restorations on the lower arch were also touched up. Okay, and at the same time, you will notice that there's also, with the retraction that we were able to do, there's also an improvement in the patient's profile. Now, to end my lecture, I'd just like to summarize our lecture in 3 key points. First of all, planning for restorative and prosthodontic rehab sometimes require lengthy hours of assessment and diagnostic records, and lengthy treatment planning in order to achieve the best results. On several occasions, orthodontic treatment proves to be a valuable tool to make sure that long stability of those restorations will be achieved. And finally, we cannot emphasize it too much. We have to keep saying it over and over that multidisciplinary approach is essential to the success of these types of cases. All right? So I'd love to hear from you. If you want to contact me for regarding my lecture for today's topic, please feel free to do so. I'd like to thank you for taking the time to listening to my lecture. Thank you very much, and stay safe, everyone.